talk about the clinical end of FSHD and some of the things that all of you who are affected have to deal with on a daily basis, and what do we do about that. So we're going to talk about evidence-based guidelines and why are they important, and where we are with that. And I'll go through some of the evidence-based guidelines and give you some other guidelines that are based not so much on evidence, but on clinical practice and common things, not things out of the ordinary, but are important. So I'm sure a lot of you have seen this when you go to a doctor and they're reading FSH. And so fortunately for us as physicians, we have now an electronic medical record. And if you can go to the bottom, it says up to date, and you can click on that, and you can read 5 minutes about FSH muscular dystrophy before you go into to see your patient, and appear like you understand something about FSH. So that's a start, but FSH is complicated, as you all know, and it's also very variable. And so trying to set a particular guidelines is a little bit difficult. But back in 2015, we did that. This is an initiative set by the American Academy of Neurology. And it basically, what it aims to do is to create a set of guidelines that patients can look at and can take to their physicians, but also guidelines for physicians about how to deal with somebody with FSH. So there are two different brochures that are produced, one for physicians and one for patients and families. And so the evidence-based guideline, I can tell you it's a tedious, merciless process that went on for about 3 years because it's very systematic and it goes over all of the literature about the different aspects of what patients with FSH muscular dystrophy have and what kind of complications, and tries to kind of summarize all of that and create reasonable guidelines. And to the credit of the American Academy of Neurology, they give us a lot of leeway because there's not a lot of literature on FSH, especially on some of the aspects that are important for patients. And so the committee that was put together that was looking at this, we could give suggestions about what the guidelines should say that may be out of what has been published, but that makes sense. And so I'm going to go over some of the guidelines that were given back in 2015. And so the first thing was, do we have evidence about FSHD genetic testing? Is it accurate? Is it reliable? What are the risk factors for this disease? Are there measurable factors that can predict severity? This is something that, as a physician, I can tell patients, give them some prognostic information that may be important for them and for their family. And complications. What are the complications that we know the major problem that most of you deal with is muscle weakness, but are there other non-muscle complications that you have to be aware of? And so we looked at what non-muscular complications occur in FSHD and who is more susceptible. And then based on that, what is the approach to surveillance and prevention or mitigation of those complications? And then look at treatment. What evidence is there in the literature about different treatments, and pharmacologic treatments, non-pharmacologic treatments. And so I know this is a little bit not very sharp, but so the first thing was about diagnosis. And so here's going back to what Dr. Belli was discussing, and in FSH muscular dystrophy, you have type 1, which is the majority of you. There's a reduction in the number of repeats. The repeat opens up, and if you have the appropriate end, that the A allele, then you get FSH muscular dystrophy. So if you have anywhere between, if you have more than 9 repeats, then you don't have FSH. If you have anywhere between 1 and 9, you have FSH. You all know that. And we looked at genetic testing that was done, and we found that the genetic testing was very specific and very sensitive, and so it has been documented in several papers. And so this is the recommendation that was made, is that yes, you should go ahead and get genetic testing, and it's very specific and very accurate for type 1. And we also created a flow chart, a diagnostic flow chart, to help physicians look and see, where you fit, and do you have FSH? Yes, no, and how you go about doing the genetic diagnosis. So that was clear cut. At the time, though, there was nobody doing FSHD2 testing, or it had just started when we published these guidelines. So that's not in there. But hopefully in the next iteration of the guidelines, it will be there. And we have some idea about what factors affect disease severity, and some of you probably know that. So we talked about 1 to 9 repeats. Some people have between 1 and 3 repeats. Some people have 4 to 7, that's the majority. And then on the other end, 8 to 9, it should be 8 to 10 repeats, yep. The individuals with 1 to 3 repeats typically are more likely to be severely affected and start having symptoms early on. And most of the infantile, almost all of the infantile onset FSH muscular dystrophy fall in that category. And most people fall into the 4 to 7 repeat category, and that's usually wide variation. You can't really tell them very much about what the prognosis looks like. And 8 to 10 repeats are usually the ones that seem to manifest later in life and to have less severe involvement. And again, these are not hard and fast rules, but this is guidelines, and it gives us an idea about what to expect. And again, these are the 3 categories. And so non-muscular manifestations, and this was, again, this goes back to some of the other muscular dystrophies like Duchenne muscular dystrophy, where there's a lot of, or myotonic muscular dystrophy, where there's cardiac involvement, there's lung involvement, there's eye involvement, you get cataracts, you get diabetes. All of these are known complications, for example, myotonic dystrophy, that have to be followed and clearly looked after to make sure that these are not complications that affect the patients that you're taking care of. The 2 major complications that come up in FSH are and these are the major ones because they're potentially life-threatening, and that's breathing and the heart. And the issue about the heart, which went back and forth for many years about whether there's cardiac involvement in FSH, the literature is pretty clear that there's no cardiac involvement in FSH. There's no need to monitor cardiac function unless somebody is having complaints. And there's a couple of large studies done in France that looked at a large number of patients with FSH over a span of time and age. And some of them had cardiac involvement, but it was age appropriate, and based on the background, these are things that were expected and were not associated with FSH. So breathing problems. Breathing problems does happen in FSH. And one of the questions was, how frequent is it? Because again, the guidelines are important. We want to make sure that we cover everything that's important, but you want to know what are the factors that predispose somebody to getting pulmonary involvement. And we want to get an idea about how many people get involved overall. You don't want to alarm everybody, but you also want to make the appropriate decisions about when to monitor somebody. So pulmonary complications, and then again in the literature there was a lot of variation in numbers. Is it 3% of people, 2%, 10%? And I think it's somewhere in there, probably about 10%, between 5 and 10%. At that time, this is based on the evidence that we had. And it turns out that it's pretty clear that people who have a lot of truncal involvement people who are wheelchair-bound are more likely to have lung involvement. And so these are the people who need to be monitored on a regular basis. But everybody should get the breathing test at baseline and asked regularly by their physician about whether they have any shortness of breath when they exercise or when they sleep flat, and a number of other questions that may suggest that they have breathing problems when they're sleeping as well. So these are the two major things. There are other things that are also important. And so hearing and retinal vascular disease, two things that can be very dramatic and disabling, but actually they don't occur very frequently. And one of the things that we've learned, and this has been very important, is that it only happens to individuals who have 1 to 3 repeats. It doesn't happen in anybody else, based on the review of all the literature and all of the evidence from the patients that we followed. It's only those patients who are susceptible to develop that, and even within that category, it's a small percentage of people who get that. So again, it becomes important for infantile onset FSH to make sure that their hearing is checked and that their retina is examined with a dilated eye exam by a specialist to make sure that there's no retinal vascular disease that can be treated before it becomes problematic. The last thing, and it's something that's not particularly unique for FSHD, but it's common among all patients with the various types of muscular dystrophy, is pain. The musculoskeletal pain, it's a little bit and again, it usually follows the types of weakness patterns that each one of you has, and it's musculoskeletal, and we have ways of dealing with that. And it's just like managing chronic pain, and there are a lot of things that we can do and try, but there's not one fix for everybody. So treatment, and again, after putting this after yesterday's conference, some of that may have to be undone. At the point where we had these guidelines made up, there was no pharmacologic treatment. And sorry, go back here. And that's up on the top of that box. There were treatment trials done with prednisone and done with albuterol, and neither of them showed efficacy as far as changing the course of the disease or making somebody stronger. There's another surgical treatment that's been used frequently in FSH, and again, there's a lot of case series, nothing very controlled, and different methodology that was done. And the recommendation said, yeah, this may be useful, but it's very vague. And because it's very vague for a reason, because this is not a trivial surgical procedure, but it does work. And it done in, if you choose the right patient and you choose the right physician, this can be something that can be can significantly improve the arm function. And so this is one of my patients, and this is as much as they can raise their arm. And if I go behind them and push on their scapula, this is the amount of increased range of motion that they can get. So this is the benefit that they would get from scapular fixation. And again, that's if somebody is young enough, doesn't have any other medical problems, and the upper arm is still in very good shape, then I would recommend that. But again, they have to understand that there are limitations, because fixing the scapula means that this motion is limited on that side and this motion is limited. So you have to take that into consideration. For women, they can't reach back. So these are things that you have to keep in mind when you do surgery, but it does work. So choosing the right surgeon, and there are 3 procedures. The wiring does not work, the sling does not work, scapulothoracic fusion does work, and this is where you actually make a big incision, put a plate on the scapula, wire it to the chest wall, and then take a bone graft from the hip and put it in between between the scapula and the ribs so that it fuses and it doesn't break. The other procedures are really not worthwhile doing. So again, this is something that's available, but it has to be, approached carefully. Choose the right patient, choose the right doctor. So, the last thing about treatment is, other than surgical intervention and pharmacologic agents that we said do not work, at this point, I think that's going to, as Dr. Bella, you said, we're very optimistic that in the next few years that's going to change. Exercise. Exercise, for a long time, us physicians, neuromuscular specialists would tell our patients with muscular dystrophy, don't exercise, it's going to make your muscles get worse. Not true. It may be true for certain types of muscular dystrophies like Duchenne muscular dystrophy, but certainly not true for FSH. And that's something that has been shown in small studies, but there's, whether you think the benefit is enough or not, it's something, aerobic exercise is good for everybody, whether you have muscular dystrophy or not. And so it's not detrimental to the muscles and that's something that's important for all of you to keep doing. So there are limitations to the evidence-based guidelines. If you think about Duchenne muscular dystrophy, it has a very predictable course. You can tell when a young boy will come off their feet. You can tell at what point they're going to need breathing help because of pulmonary respiratory failure, and at one point they're going to get cardiac problems. But that's Duchenne muscular dystrophy. FSH is very different. There's a wide spectrum of involvement. It is unpredictable in many ways. And you can't have a set of evidence-based guidelines, a one-size-fit-all guidelines. And most of the studies that we've done are retrospective case series. And one of the issues is, whatever comes up from these studies that we've looked at, are the numbers wide enough to make generalized statements about everybody? Have we covered everybody or not? And this issue came recently after we published those studies about breathing problems. And again, there was an alarming study done from the UK that showed almost 40% of patients that had breathing problems. And I didn't believe that. I've never seen that. Nobody has ever published that. And again, you have to think about who are the patients that they looked at. Are they just a cross-section of everybody who has FSH, or is it skewed to patients who are more severely affected? And when you look at the publication, this is what it was, and they made the statement that 40% of patients with FSH are going to get breathing problems. I think that's, you should be very careful about saying that because the evidence was not there at the time. But again, that's something that still needs to be looked at, and at some point we have to upgrade those guidelines. Again, one of the things that is missing in the present guidelines is testing for FSHD type 2, and if some of you have attended the scientific meeting, you see it's kind of more complicated to kind of define those, exactly what you have to do for diagnosing type 2. So I'll give you a couple of things that are not based on, it's not evidence-based guidelines specifically for FSH, but some things that make sense that have been used for other diseases that may be applicable to FSH muscular dystrophy. So this is one. Weakness of the eyelid muscles. As you know, patients who are very affected can't close their eyes. And that can cause exposure keratitis and can injure the surface of the eye. You can get inflammation, infection from that, and that can be serious. And there is evidence that there is a surgical procedure that can be used, and that's been frequently done on patients who have a Bell's palsy, where they have one side of the face that's weak. And you put an implant, a gold weight in the upper eyelid, as you can see in the bottom right corner. The gold plate is just put on top of the skin in this they figure out which is the right weight, and then they put it on their skin. And this helps close the eyes and prevent the exposure injuries. And again, one of my mentors at the University of Rochester always said, listen to your patients, and you have to listen to, I have to listen to my patients because they teach me a lot. And because they will go out and we'll look for answers for some of the things that we don't have answers for, and they'll come back and show me what they've done, and some of it does work, and some of it does make sense. Lower facial weakness can lead to a floppy lower lip, and that can impair speech. It can cause drooling and spillage of food when you're eating. And there are some minor surgical procedures that are used that can help with that, both for cosmetic improvement, but for functional improvement. The young lady who was a social worker in a hospital down in Alabama, and she had a surgical procedure done like that. Her colleagues were understanding her better, and her patients that she was seeing. And she was, that was a big improvement in her quality of life. So these are small interventions. Again, these are some things that you can do that are not thought about very frequently, but these are things that may help a lot in individual patients. So how do we improve care guidelines? So again, we need more longitudinal information in a larger number of individuals with FSH. That's going to help us understand what happens with somebody who has FSH over time. The only way to practically do that is through a registry. And I'm kind of teeing up for talking about the National Registry based on that. But it's really true. I mean, we learned a lot from the registry. There's potentially about 20,000, again, there's potentially 20,000 patients with FSH muscular dystrophy in this country. The National Registry has about 1,000 patients right now. That's not a representative cross-section of the population, and I think I would urge anybody who's not involved in the registry to do that. And I'll talk a little bit about how the registry functions. The registry has been going on for 18 years. It's based in Rochester, but it's a national registry. And the purpose of the registry is twofold. One is to learn about FSH by looking over time about what happens to somebody with FSH. And somebody who has FSH will fill long questionnaires initially, and then there'll be follow-up questionnaires on a yearly basis. And Dr. Statlin, one of my colleagues and partners in research in FSH, has looked at some of that data and has been able to predict some endpoints and how long it takes to move from one degree of disability to another in general in patients with FSH. So the more patients we have, the more we're going to have a representative picture. The other part of the registry is that it will take anybody who's a member of the registry and connect them with researchers who are interested in somebody exactly like them, that feels for research that in whom the researcher is looking for somebody with their particular profile. We never share any medical information with the researcher, but the researcher applies to the registry. We then tell them we have 100 patients who fit your criteria. We're going to send them a card saying, Mr. So-and-so, Mrs. So-and-so, you qualify for this study done by Dr. Mitchell at the University of Minnesota. If you're interested, this is the research study. If you're interested, you contact them. So there's never any release of identifiable data between the registry participants and anybody else. One of the things that has been limiting the registry is the fact that about 40% of the patients in the registry are not genetically confirmed. And really, for research, for a clinical trial, we need that. And fortunately, the FSH Society and Friends of FSH Research have come to the rescue a couple of years ago and they've provided funds for us to actually help those who can't get genetically tested, who are in the registry, to get genetically tested. And this will be done by my colleague in the Netherlands, Dr. Sylvain van der Marl, and he's doing it at almost no cost, basically. So this has helped us increase the percentage of patients within the registry that are confirmed. But I hope we can, over the next few years, at least double the number of patients in the registry, because then it doubles basically the amount of useful information that we can look at. And I will stop at this point. And I wanted to thank the FSH Society for inviting me to this, and also everybody within the FSH community, all of the patients and the families that have participated in the research that I've done over the last 28 years. Thank you.